Greetings to everyone. This pandemic has brought us all together. The pandemic has produced an enormous and extraordinary challenge, but I'm very confident that this extraordinary challenge can be defeated by doing ordinary things with extraordinary discipline. I welcome you all to the Global Coalition webinar series on COVID-19, the pandemic. I welcome you all on behalf of the Asian and the Oceanic Society of Regional Anesthesia and Pain Medicine. On behalf of the board, I'm the current officiating president of this organization. I'm Dr. Bala Venkat, consultant anesthesiologist at Ganga Hospital, Coimbatore, India. I also bring to you greetings from the board of directors, President-elect Dr. Kong Kwei Tang from Vietnam, past president, Dr. Masataka from Japan, our secretary, Dr. Subimon Thangvivet from Thailand, our treasurer, Dr. Ashoka Balakrishnan from Singapore, our academic director, Dr. Louis Mo from Hong Kong, our board of directors, which includes Dr. Sakridan Fatil from Malaysia, Dr. Yong Jin Lim from Korea, Dr. Ong Ki from Myanmar, Dr. Popak from Iran, Dr. Shagdar from Mongolia, Dr. Priyam Bado from Indonesia, Dr. Dalia Rinsel from Philippines. We are 28 member countries which are active in this organization of this geography. And today we are extremely delighted to have a joint session. Aosra-Pm joins with one of the largest federations of our country, the Federation of Obstetric and Gynecological Society of India, and the Association of Obstetric Anesthesiologists of India. Also joining with us is the International Academic Exchange Committee of FOGSI India. I take this opportunity to immensely thank Smiths Medical India for the opportunity, the sponsorship, and all the activities they have done to make sure that this webinar takes its shape. I immensely thank Yash Kaul, Dairav Dalal, Raghuram, and Ravi for having put in so much of energy for making this possibility and enabling us to share the knowledge globally on a very pertinent and important topic. Today, I'm extremely happy to share that we have close to 5,000 registrations from 63 countries. I take this opportunity to welcome each and every delegate from the nook and corner of this globe for being part of this webinar. And I'm sure the exchanges that takes place here will result in pertinent changes in the clinical practice. We will together decrease the mortality and eventually win this pandemic. I'm extremely happy and delighted to the keynote speakers, Dr. Arvind Palniswamy, Dr. Jean Kelly, Dr. Miha, Dr. Bhavani Kodali, Dr. Lisa Leffert, the panelists who are going to add value to this webinar, Dr. Sunil Pandya from India, Dr. Hyuga from Japan, and Dr. Reena Vani from India. I also would wanted to tell all the delegates, all the participants, that the certificates for attending today's webinar will be available for a direct download from the 5th of June in this website, the aosra-pm.org. With this introduction, may I request the marketing director of the Smiths Medical of Asia Pacific region, Mr. Dairav Dalal, to share his thoughts and welcome everyone on behalf of Smiths Medical.
Thank you, Dr. Bala Venkat, for giving us this opportunity, and thank you to ASRA for giving us this opportunity to partner with you on this great initiative. This is a very important topic for us, given our deep history in anesthesia, our global presence with our Portex brand. I also want to thank Dr. Arvind Palniswamy for putting this entire webinar together and for helping us with the speakers from the US, as well as having us speakers and the panelists from India, Dr. Pandya and Dr. Vani, as well as Dr. Hyuga from Japan, for making this a truly global initiative. We're really excited to be sharing this knowledge for everyone today. Thank you, Dr. Bala Venkat.
Thank you, Dairav. And it's a great pleasure to invite the president of the FOGSI India, Dr. Alpesh Gandhi from Ahmedabad, to welcome the gathering and share his thoughts.
Very good evening to everyone. I am thankful to Dr. Bala Venkat for the introduction, and I am thankful to ASRA, AOA associations for the joint program, a very needed program in this time, and a good number of presence shows that it is very required, a good high quality scientific program. So definitely going to be a good attendance also. I would not take much time. In next 3-4 minutes I would like to introduce FOGSI to all the international delegates and our national delegates also, anesthetist friends also. FOGSI is the Federation of Obstetrics and Gynecological Societies of India. We have 260 societies like Delhi Society, Mumbai Society, Ahmedabad Society, Bangalore Society, like that. We have 260 societies. FOGSI is one of the largest federation of any medical specialty, not in India but in the world, with nearly 40,000 members. And we have now also our international chapters. We have branch in London, also in the USA, and this year it was going to start in Australia, but in lockdown, it was going to start in the month of August. But in the period of lockdown, I think it will be difficult. It will be postponed for few more months. So we have our international chapters also presence at in different countries also. Our primary aim, main mission is to reduce maternal mortality, neonatal mortality, and morbidity, and to promote and advocate sexual and reproductive health and other aspects of women's health care for the upliftment of women's health care in India. And we are also very much active in SAFOC countries, South Asian countries. In recent time of COVID-19, I would like to take your 2 minutes to inform what the activities we have done at the level of FOGSI. We immediately switch over to digital platform, and we have conducted nearly 30 webinars. Every day we have important webinar. We also organized 2 web conference for the whole day, and we have prepared a calendar of 96 webinars which is there on our website. But apart from this, very important work we have done is we immediately came out with the good clinical practice recommendation guidelines on pregnancy with COVID-19, and another guideline on pregnancy for COVID-19 with perinatal and neonatal management in COVID-19. And both the GCPR are very well appreciated with positive feedbacks from many parts of the world, and of course in India by ICMR and Government of India. We also came out with our registry, and our registry became very popular with very good data in a short time, and probably in next 6 months I can say we may have the biggest data in the world in this registry of pregnancy with COVID-19 infection. And we also came out with the FAQs, frequently asked questions, and we also came out with the second version, and now we are ready with the third. We are working on the third version of this GCPR. So looking to our work on all the direction, we also are ready to start our helpline number for this COVID-19 and pregnancy and gynec conditions. Looking to all our prompt action, proactive action on all the directions. We are invited by ICMR for the Government of India's GCPR. We are invited by ICMR and Government of India for the National Registry, and we were invited for Prime Minister had organized a video conferencing with different association where we were invited and given an opportunity for our humble suggestions, and Prime Minister office has accepted implemented our 4 suggestions out of 5 suggestions. So we are considered, heard, invited, and our opinions are taken. And now looking to our registry, FIGO, our world organization, has invited us, and Imperial College UK invited us for the world registry also. So our work during this pandemic is for the guidelines, GCPR, registry, frequently asked questions, and many other work is getting recognized across the world and very, very beneficial to all our members and our patients. So with brief introduction of our work, our mission, and our association, I am once again thankful to all of you. I wish great learning, a very a good day, and I am thankful to once again Bala Venkat for this opportunity. Stay healthy, stay safe, and please take care of yourself, your parents, your family members, your staff members, and your colleagues. Thank you very much, Dr. Bala, for this.
Thank you, sir. Thank you so much for that introduction. And I have great pleasure in introducing one of the key persons of today's webinar. Through him, we did everything possible. So we directly go into the academics now. I have great pleasure in introducing Dr. Aravind Palaniswamy, MD, FRCA. He's the Division Chief of Obstetric Anesthesiology and Associate Professor of Anesthesiology at the Washington University School of Medicine, St. Louis, US. I'm very happy that he belongs to the same city where I studied, the same medical school I studied, the Coimbatore Medical College. Over to Dr. Aravind Palaniswamy for the first talk.
So thanks, Dr. Bala Venkat, for this wonderful introduction. And a big thank you to both Aosra-Pm and FOGSI to host a combined webinar, because it sends across a very powerful message that both anesthesiologists and obstetricians should be in this together, because this is not a battle that could be fought alone, and it has to be fought together. So without further ado, this is the lineup of all the talks we have today. So I will be talking about the epidemiology of COVID-19 in pregnancy, and then we'll have a series of 4 lectures. 2 of them would deal with the preparation of labor and delivery unit for providing high quality care, and the last 2 lectures will provide more information on the nitty-gritty of anesthetic management and special considerations. So with that, I would like to introduce all the speakers. So I'm going to start with Jeannie Kelly, who's going to succeed me in the E-podium. So she is a medical director for the Obstetric Inpatient Services at my institution. She's also an assistant professor of obstetrics and gynecology in the Division of Maternal Fetal Medicine. And her talk would be on how to foster multidisciplinary collaboration to enable high quality care. And her talk would be followed by Dr. Mihaela Podaway, who was one of the primary authors for the interim guidance statement for managing COVID-19 patients that was put out by the Society for Obstetric Anesthesia and Perinatology. So she's a director for quality assurance and improvement at the Brigham and Women's Hospital. She's an instructor of anesthesiology in Harvard Medical School, and she belongs to the Division of Obstetric Anesthesia. Following Mihaela Podaway, we will have a wonderful talk by Dr. Bhavani Kodali, who's the Division Chief of Obstetric Anesthesia and the Chief Safety Officer for the Department of Anesthesiology at the University of Maryland School of Medicine. So he will be dealing with the anesthetic management of the COVID-19 patient, sharing some of his personal experiences of over 21 cases. Following Dr. Kodali's talk would be Dr. Lisa Leffert, who's the president of the Society of Obstetric Anesthesia and Perinatology and the Division Chief of Obstetric Anesthesia at Massachusetts General Hospital. She is also an associate professor of anesthesia at Harvard Medical School and the vice chair for faculty development. A warm welcome to all the speakers. So without further ado, I'm just going to quickly jump into my topic, is to provide a broad epidemiological overview of COVID-19 in pregnancy and set the framework for the discussion to follow. I'm sure that you're sick and tired of seeing this image over and over again, this spiky and sneaky coronavirus has collectively hijacked all of our consciousness. It has fundamentally changed the way we interact with each other, the way we interact with patients, and the way we are viewed by the society at large. And it's also brought into question some of the fundamental, clinical practices that we have taken for granted. So before we dive into the topic, I think we need a basic primer on what exactly is COVID-19 and what causes it. We all know that it's caused by the SARS-CoV-2 virus. And the primary portal of entry is the nasal epithelium and maybe a little bit of the olfactory epithelium. So the virus actually uses the ACE2 receptors, which is expressed in the ciliated epithelial cells. And there's another important protein called the serine protease, which actually helps in cleaving that spike and enabling the virus to enter into the cell. And once the virus is in the cell, it hijacks the machinery and actually uses the intracellular machinery to replicate itself, eventually leading to release of new mature virions, as well as damage to the host cell, which is called pyroptosis, which results in release of inflammatory mediators and activation of cytokines. So what is the typical outcome? Usually in about 85% of the patients with good, healthy immune response, the virus is typically cleared within 2 to 3 days. But unfortunately, about 15% of them would have severe disease. And these are patients who would show a dysfunctional immune response. So this could be related to host factors, as we all appreciate now. It could be related to the viral factors, or it could be the viral host interaction. So we really do not have a good handle on what really causes the severe disease. And a small proportion of these patients, about 5% of them, will end up having a cytokine storm, which can cause multi-organ failure and high mortality. So what are the changes in pregnancy that results in an increased susceptibility to infection? So we know that we call a pregnancy as a state of relative immunosuppression, and I think that's a misnomer. I think it's more of a state of immunological laziness. And I say that because it's not that the immune system is completely suppressed, because we still have a good alpha defenses in the mucosal system. So what happens during pregnancy is a downregulation of T-cell mediated immunity and diminished proliferation of lymphocytes to soluble antigens. But what's important to recognize is that there is an intact or even an upregulated humoral response to infection. So if you look at how the two arms of the immune system are regulated during pregnancy, you can see clearly that the cytotoxic cell-mediated immunity is downregulated starting from the second trimester, whereas the alpha defensins and all the polymorphonuclear cells are upregulated from the second trimester onwards. So you have this nice diversification. But the problem with this is that there is an increased severity of influenza and other viral infections, especially during the third trimester of pregnancy. So to better understand what the impact of COVID-19 would be, because we are still actively trying to figure out what exactly is going on, I thought it should be a good practice to look at the previous pandemic influenzas. So I actually picked three: the 1918 Spanish flu epidemic, the pandemic, and the 1957 pandemic, and of course the 2009 swine flu pandemic. So I have three important rows here. I'm talking about the ICU admission rates, the mechanical ventilation rates, and the mortality rates in pregnant subjects. Obviously, we do not have much information for the 1918 and the 1957 pandemics, especially with regards to ICU admission and mechanical ventilation. Maybe in 1918, we didn't even have ventilators. But what we do know is that the mortality was 20% higher in pregnant women in the 1918 pandemic. And the case fatality rate was almost 50% at one point in time, which means that 1 out of 2 pregnant women with the pandemic influenza would actually die. And this was actually replicated in the 1957 pandemic as well. And if you look at the most proximate influenza pandemic, which is the 2009 pandemic, you can see that the ICU admission rates were about 5.6% and the mechanical ventilation rates similar, despite pregnant women being only 1% of the population at the time. What's also important to note is that with this pandemic, we had a 4 times higher risk for hospitalization of pregnant women and a 5 times increase in mortality in pregnant women compared to non-pregnant controls. But what about a comparison with the other coronaviruses? I know that influenza viruses are different from coronaviruses, so I think it makes sense to compare COVID-19 with the other two pandemics, which was the severe acute respiratory syndrome in 2003 and the Middle East respiratory syndrome in 2012. And you can see that the presentation of COVID-19 is vastly different from all the previous coronavirus pandemics. So you can see that in pregnant women especially, almost 50% of women were admitted to the ICU and almost 40% required mechanical ventilation. So with SARS and with MERS. However, with COVID-19, based on all the data I've collected so far, the rates seem to be much lower. It's about 10% for ICU admission and 5% for mechanical ventilation. And if you look at the mortality rates, this is stunning. With SARS and MERS, you see almost 1 out of 4 pregnant women dying. But so far with COVID-19, at least the big case series that have been published so far, no deaths have been reported. I know that that's changing, and it is likely to change over the next 2 to 3 months. But I'm just presenting the data that's been published so far. So with that, it's interesting to talk a little bit about this epidemiological enigma. What is so unique about SARS-CoV-2 in pregnancy, and why do we have this kind of presentation compared to influenza viruses and other, coronaviruses? So what is striking is that there's a really high rate of asymptomatic carriers in pregnancy, which is very different from influenza, where they become symptomatic pretty quickly. So I'm actually highlighting 3 studies from 3 major centers along the East Coast, from New York, Connecticut, and Boston. And you can see that the rate of asymptomatic carriers is so high. It's about 88% in New York, and that was the landmark research letter to the New England Journal of Medicine. It's about 73% in Connecticut and about 45% in Boston. So there's a pretty high rate of asymptomatic carriers in pregnancy. And the second most important facet is that the disease appears to be less severe in pregnant women, probably the same as that of any age or sex match controls, but it's definitely not as worse as the influenza pandemic. For example, I have data from China, from Wuhan province, where almost 92% of all pregnant women had only a mild infection, again, 0 mortality. We have data from Washington State, which was published about 2 weeks ago. Again, 85% of patients had really mild or asymptomatic. And then we have data from Northern Italy, which is the paper by Ferrazzi et al., which is at the bottom, which is published in the British Journal of Obstetrics and Gynecology, again, showing that 90% of patients have mild to asymptomatic disease. So the 2 main things to remember is that you have a high proportion of asymptomatic carriers, and the disease severity is much less than what you would expect, say, with influenza. But what about the severe COVID-19 patients in pregnancy? And I can come across only one study that's been published, and this came out about a week ago. So this was a cohort study in the United States involving about 12 institutions, where they selected only those with severe or critical disease, which they defined according to a standard criteria. So this study recruited about 64 patients across 12 institutions. And about 1/3 of these patients required intubation, and almost 70% developed ARDS. So these are the sickest of all patients. And in fact, about 1 out of 4 of these patients were actually subjected to prone ventilation. So again, consistent with the previous theme, even in this highly selected group of severe and acutely ill pregnant women with COVID-19, the mortality rate was 0. So it's actually really impressive, and we need to figure out more on why this is happening, which is actually good, but we need to figure out why. So this is like a latest summary slide. This was published just 2 days ago about the treatment and outcomes of pregnant women with COVID-19. And I would like you to focus on the little table at the far right on maternal mortality. You can see that everything is pretty much 0, except for one paper from Iran, which suggested that there was a pretty high mortality rate in severe COVID-19 in pregnancy. So that's the only outlier I can find so far. But in general, data from China, data from Italy, and data from the United States suggest that the mortality rate is not as high. So before I share my podium with Dr. Jeannie Kelly, there are two important questions that keep popping up. And I think both of these questions are highly relevant to all the participants. One of the first questions is the second stage of labor an aerosol generating procedure? And the answer is it is highly likely. And the second question is there any evidence for vertical transmission? You know, a transmission to the baby, obviously it'll have implications for neonatal resuscitation and also homing of the mother-infant dyad. And the answer for that is it's unlikely, but again, we are just about starting to see some new data. So I'm going to dive a little bit deeper into the aerosol generating component of second stage of labor. Obviously, there's no study that has looked at it, and I think it's a great research opportunity to really test the notion whether the second stage of labor, especially the huffing and puffing for a prolonged period of time, generates aerosols. I think it's a really, really important study to do. But what I did find was an interesting study that was published in 2012 in patients that were infected with influenza. So these are not pregnant patients, but just regular non-pregnant subjects. But what they did here was they wanted to see what virus, what proportion of viruses were released in the aerosol with forced exhalation. I know that all the people who have logged in know what forced exhalation means for the second stage of labor. And so this is the closest study that I could find. And I was actually surprised to see that mature virions were released into the aerosols 24% of the time, with forced exhalation compared with 41% with cough. So it's actually pretty high. So the answer to the question whether second stage of labor is an aerosol generating procedure, it's most likely. And the other thing to remember is the prolonged duration of contact in a patient who is in second stage of labor, because this huffing and puffing can go on for up to 2 hours, for example. And so there's prolonged contact with aerosols, which may have mature virions. So I think you should be extremely careful, even though a lot of societies have declared that we don't have data. But I think the more I read the literature, the more convinced I am that we need to be extremely careful, especially with the second stage of labor in symptomatic patients. So the reason why aerosols become important is because the WHO initially said that it was spread by droplets, and there were no airborne precautions. But this study that was published in Nature 2020 was very instrumental in changing the policy of the WHO, and then suggest airborne precautions as well. And in this particular study, what they did was they went around 2 hospitals that were dedicated to the care of COVID-19 patients in Wuhan. And they actually collected the aerosols from different locations within the hospital. And what they found was that, there were 2 predominant aerosol particles, one less than 1 micrometer in diameter, and the other greater than 2.5. And you can see that the submicron particles had about 40 copies of the SARS-CoV-2 viral RNA. So this is not the mature virion, but the RNA. So it is definitely there in the aerosols, and especially in hospitals taking care of these patients. So just be careful. So the second, I think, was very well publicized, and this study came out in the New England Journal of Medicine, where they actually simulated aerosol production within a drum. They loaded it up with SARS-CoV-2 virus, and what they found was that within an aerosol, the virus was viable up to 3 hours. So in the top left corner, you see the viral titer. You start with 1,000 virions at 0 hours, and by the end of 3 hours, it's still about 100 to 1,000 virions. So it kind of remained stable for up to 3 hours, which was the duration of this particular study. And on the bottom graph, you can actually see the half-life of all the aerosols, and it looks like the median half-life is about 1.1 hour. But what is important to emphasize is that none of these studies actually looked at the infectious risk. These are all in vitro studies, so I think we need more information. But what it tells you is that aerosol generation is a distinct problem with second stage, and especially if you have an infected patient or even an asymptomatic carrier for that matter, they are highly likely to generate aerosols which can remain in the circulation for a long period of time. So the second question pertains to vertical transmission. And I think to better understand this topic, we need to know whether all the viral receptor mechanisms are expressed in the placenta. So I talked about the angiotensin converting enzyme 2, which is the receptor for SARS-CoV-2 virus. And this is a paper that was published in Nature. And what I'm going to show is these two circles. This is a single cell RNA sequencing of the different cell types in the placenta. So the top circle is actually the villus and the extravillus and the syncytial cytotrophoblast. And the bottom circle are the stromal cells. And the green dots on the right actually are the ACE2 genes. So you can clearly see that starting at about 6 weeks of gestation, ACE2 starts to get expressed. So there's a possibility that vertical transmission can occur as early as the first trimester of pregnancy. Again, we don't have any data, and we will only know probably about 6 months from now. What's also interesting is that the ACE expression increases throughout the gestational age, and it's maximum during the third trimester. So there's definitely all the receptor mechanisms in place to enable vertical transmission. But what does the data show so far? This is what we're all concerned about, right? And so the answer to that is, and primarily because the overall incidence of viremia, because you need to have the virus in the blood to be able to be transported to the placenta and enable it to cross the placental barrier. And it turns out that the incidence of viremia is about 1%. It's extremely low. In fact, one of the initial studies from China actually showed that they were not able to detect the viral RNA in the blood. And there were a couple of other studies that I wanted to highlight. The most pertinent study is a study by Chen et al., which came out in the Lancet, where they actually did assays for SARS-CoV-2 in the umbilical cord blood and also did neonatal throat swabs as well as the amniotic fluid in about 9 pregnant women. So none of these women actually had SARS-CoV-2 either in the amniotic fluid or in the umbilical cord blood. So this was one of the first papers that came out that suggested that maybe there is no vertical transmission. But we've had a couple of new papers that have come out by Penfield and Zheng. Both came out the last 2 to 3 weeks. And they actually show that there's probably a very small likelihood of vertical transmission. In one of the studies, at least 3 out of 11 placental samples had positive SARS-CoV-2. The interesting thing to note is that even if it's located in the placenta, it doesn't mean it gets to the baby, because none of the babies born to these mothers actually tested positive for SARS-CoV-2. So just locating the virus in the placenta is not evidence for vertical transmission, but it increases the likelihood that it can get to the baby. And the last study by Zheng actually looked at 33 neonates, all born to mothers with severe COVID disease, and 3 out of the 33 ended up positive for SARS-CoV-2. And what's interesting to note is that all 3 babies were born via cesarean delivery. So with that, I would like to stop my talk and transition to our next speaker, Jeannie Kelly, who will be talking to us about how to foster multidisciplinary collaboration in labor and delivery. Jeannie, over to you.
Thank you so much for having me here. I am a maternal fetal medicine physician at Washington University in St. Louis, and I will be discussing our experience and our pathway in fostering multidisciplinary collaboration and how we did it at our hospital to deliver high quality obstetrical care to COVID-19 participants. And I have no disclosures. So here in the United States, we have recently surpassed 1.79 million cases of COVID-19. And just this past week, we have surpassed 104,000 deaths, putting us in the lead worldwide currently for number of cases and deaths. We are here in the middle of the country in the state of Missouri. For the most part, we have been spared the worst of this infection so far, which has hit the coasts the hardest. Here's a close-up of our state. Where Dr. Palasamy and I work is here in the city of St. Louis, which has the most and worst severe outbreak of COVID-19. In our counties, we have the majority of cases for the entire state and the majority of deaths. In our hospital, which is Barnes-Jewish Hospital, affiliated with Washington University, we are considered a medium-sized tertiary care center here in the States. We have about 10,000 employees, 1,200 beds. We operate in Parkview Tower, which is here on the left, which opened just about 2 years ago. We have 18 labor beds, 12 triage beds, 18 antepartum beds, 34 postpartum beds, and 3 operating rooms, one specifically for fetal surgery for things like in utero myelomeningocele repair. Again, we're about a medium-sized tertiary care center with 3,600 deliveries. We have about 550 transports to our delivery unit a year. And we are connected here, as you can see by this little sky bridge, connected directly to our children's hospital, which is across the street and holds 150 NICU beds at St. Louis Children's Hospital. So when we started looking at our hospital response to COVID-19, there quickly formed a hospital command center to oversee the policies and direction of how the hospital would respond to this pandemic. And we were, of course, the obstetrical offshoot from that hospital command center. As we all know, the practice of obstetrics is a team sport. More than any other specialty in the hospital, we have a large multidisciplinary team that has to take care of not one, but 2 patients. So with, innately connected to the practice of obstetrics, you have anesthesia, you have pediatrics, and with pediatrics, you have neonatology. And in addition to the neonatology team, for all of these practices, you have a nurse leadership and a nurse parallel team who helps very much with all of what happens on labor and delivery, which is kind of our own unit of an emergency room, an ICU, of an anesthesia unit and operating rooms. And what we found early on was that we were dealt with sort of as an obstetrical unit, and the hospital also had other sort of spokes in their wheel. So with emergency medicine, with critical care, and with infectious diseases. But what was less clear from the beginning was that the policies that affected emergency medicine, even though they were deemed a separate specialty from obstetrics, directly affect obstetrics as well, because we also function essentially as an emergency room for pregnant women. And whatever came down about critical care also directly affected us, because we also sometimes function as an ICU for pregnant women. And obviously whatever affected infectious diseases also affected our patients in the way that we treated our patients with COVID-19 on the labor and delivery unit. And it became very clear early on that obstetrics was a unique field in the entire hospital that crisscrossed paths with a large proportion of other specialties. And it was extremely important that we were all talking to each other and understanding that we were on the same page. So what problems have we run into as a hospital and as a unit, and what were our best solutions? I believe that these are universal as everyone readies their hospital and their system for COVID-19. Problem number 1, there are so many people involved, as I just showed you, in the practice of obstetrics, and there's so much parallel work happening, in other divisions and departments of the hospital that mirror what needs to happen on labor and delivery. So one of the first steps that we had to do was identify the team. And essentially, we had to identify one point person from each of these specialties, from the hospital leadership, from infectious diseases, from critical care, emergency medicine, obviously OBGYN, anesthesia and the pediatric neonatology side, because every decision and every policy that we set into place as a labor and delivery unit specifically affected each of these specialties and their care for our patients on labor and delivery. We began holding bi-weekly teleconferences between all of the leaderships in these teams, reviewing exactly what was happening on labor and delivery and going over new policies and new direction and what needed to either change or needed to develop in our policies to best care for our patients and protect our healthcare workers. This was the first flowchart that we put together in the beginning of our response. This was in March of, mid-March, where we started this. I put this together kind of as the obstetrical liaison. I thought at the time this seemed a little bit complicated, but seemed the flowchart relatively easy to follow. What started to happen with all of this intense information and changes that started happening at the hospital level, we tried to keep up and try to parallel and mirror all of these policy changes. Multiple revisions to this flowchart has since occurred since the first day we started this in March. And I'll show you, this is our most recent updated flowchart from just a few days ago. As you can see, the complexity has truly grown over the last couple of just a few months as the hospital response and our response to a COVID-19 patient has gotten more complicated, and as we identify more problems to solve. Problem number two is email fatigue and change fatigue and policy fatigue. We get so many emails every single day from the hospital, from our practice, from our department, from our divisions, and there's so many changes that happen every single day that it is impossible to keep up or to expect your staff and your colleagues and your partners to keep up with every email that you send out, no matter how long you spend on it trying to make it what you think is easy to read. And so what we found was that we needed a centralized place to put all of these updated protocols and updated changes so that when someone had a question or a problem on labor and delivery, they could just pull up the centralized location. There really needs to be a very small group who has direct access to how to update this web-based centralization of all of your protocols. And that one person needs to be able to frequently update it in real time. We need to all think about every email that we send out. Is it really necessary to send out in an email way? Because lots of people are just no longer reading their emails because it's so impossible to keep up with. And we also really stress to our staff, we understand it's so confusing and so hard. We really try to be as flexible as possible. And the leadership from the OB and anesthesia side have really tried to make ourselves essentially available to our partners and our staff 24/7 for clinical questions that come up. You may think that your flow chart is really conclusive and really good at answering all the questions and clinical scenarios that may pop up, but that's actually not true. Confusing things pop up all the time that need clarification and need immediate clarification from leadership. We also created a whiteboard on labor and delivery that was updated every single day, that went through the changes that happened in the email every single day. So it was a quick reference for people who were physically in labor and delivery to look up and say, this is the recommended PPE at our hospital for this situation. This is the workflow for a patient with COVID-19. These are the important numbers that we need to call when this happens. And this is the workflow for a baby born to a mom who is COVID-19. And this is the current visitor policy at the hospital. This is reviewed at every single nurse and every single staff shift change actively so that everyone at least knows where to look for the most updated information. And then our third problem that I wanted to address is there are, I think, several hot topics that are controversial and are points of contention, and policies are made that have a vast amount of downstream consequences that may not all be completely thought through. And being in the middle of the country, we really watched a lot of our coastal colleagues go through this epidemic 1 to 2 weeks ahead of us in the curve. And we learned a lot just by watching them and understanding what are the pressure points in a hospital and in a labor delivery system, and how do we best plan ahead and think about how to disseminate some of this information. Personal protective equipment, or PPE, is a huge controversial topic. We have here in the United States a large PPE shortage of N95s, of PAPRs, of even surgical masks, and at one point surgical gowns and just non-latex gloves. This became a huge point of contention. We have multiple organizations with multiple recommendations of what type of PPE is appropriate for what parts of anesthetic nursing and obstetrical care on labor and delivery. And as our hospital rolled out policies for PPE, it became very clear that they didn't really understand what we did on labor and delivery. And a lot of the policies that initially came out didn't include us or didn't think of us as a unit. You know, the emergency room got certain PPE, but they didn't realize that obstetrical triage also were seeing the same sort of patients who walk in off the street, and those providers are extremely vulnerable in the same way that the emergency room is in a hospital. And so, you know, there was a lot of back and forth with PPE. So this was a very controversial point that is important to talk through at a hospital level to make sure that everyone is on the same page and that we feel comfortable with what policies are there for the protection of our own healthcare workers. In addition to PPE for healthcare workers, there's also PPE for patients. The question is, will there be a policy about patients coming in? And will they be expected to wear a mask, and for how long? And where does the mask come from in this PPE shortage? There are, you know, sort of best policies to protect healthcare workers and the patients, but there's also the reality of the availability of PPE and the capacity of the hospital, the state, and the country to provide that PPE. So you have to somehow balance your policies where you don't burn through PPE, but also protect your workers. Negative pressure rooms was another point of contention. What specifically has to be done in a negative pressure room? What procedures, deliveries, et cetera? Which negative pressure rooms do you have available? And if you make policies, will you outstrip the capacity of the negative pressure rooms that you have in your unit? Are your operating rooms negative pressure? And if they're not, how do you handle surgery for a patient who is COVID positive or a person under investigation? What is the visitor policy at your hospital? I think the visitor policy is very different from a patient who comes in, the emotions surrounding the visitor policy for an obstetrical patient who comes in to deliver their baby versus someone coming in and admitted for pneumonia on the medicine service. You know, what is going to be the obstetrical and labor and delivery visitor policy, and how will you roll that out on your unit? Mother-baby separation is another point of contention. Here in the United States, we had a statement from our Center for Disease, CDC, about a pretty strong statement supporting mother-baby separation that over the last few weeks has been walked back a little bit. This is obviously a huge deal for some of our patients. Certainly if someone is critically ill, they can't be caring for a newborn. But if there's a policy of you know, mandated separation for all COVID positive mothers, for the mildly ill or the asymptomatic mothers in your institution, how are you going to teach that mother how to take care of their newborn if you're going to separate that baby from her immediately following delivery and then hand that baby back to her upon discharge a day later? How does that kind of workflow happen, and how do we think through those policies? And last but not least, universal testing for all deliveries who come onto your labor and delivery unit. As Dr. Palasamy alluded to, the first paper that came out that talked about an asymptomatic carrier rate for patients coming onto labor and delivery came out of New York City at Columbia, where there was a huge percentage of an asymptomatic carrier rate. There have been multiple papers coming out from that as well, including from places that are a little bit less hit here in the United States. So one paper came out recently from Los Angeles, where the rates are a little bit lower, and there was a 0% asymptomatic carrier rate. Universal testing is a large burden to place on your providers and a large burden to place on your patients. What happens if someone has a test pending? Do they have to be treated as a person under investigation with all of the PPE? So how much PPE are you going to be using if you have to test every single patient as they await their results? What if somebody refuses testing? How do you treat that patient? And will you mandate all of the COVID-19 precautions for a patient who refuses testing? And in thinking through all of these points and talking through all of these policies with all of the teams that will be involved in the care of a mother and her newborn, how do these policies affect your most vulnerable and your most high-risk patients? We certainly cannot solve health disparities. We couldn't solve them before a global pandemic, and we can't, solve health disparities in the middle of a global pandemic, but we certainly have to keep in mind very much the downstream effects of every single policy that comes into play and how that worsens the health disparities at your hospital. We also held multiple COVID-19 simulations, and in the beginning of our time there, this is one of our labor and delivery rooms that was negative pressure that we actually turned into an operating room. This is the antechamber ahead, which has been stocked full of all of the equipment that we need. And here is entering into the labor room, which is just a normal labor room, but we essentially equipped to become an operating room if necessary for our COVID positive mothers to be delivered via C-section directly in the room. And what we learned from these simulations is that, number one, in the heat of the moment, it's really hard for our providers to remember what PPE to put on and in what order. So our solution to that was to post very clear signs delineating what PPE policies we had at the hospital and how to put them on. Donning and doffing are really hard to remember because this is not typically something that we do. These are our providers undergoing the simulation. Instead of burning through some PPE, we actually just call out the number, the order of PPE and how to put things on. And then problem number two is intubation. We know from obstetrics that our patients can be intubated at any time unexpectedly, which is considered an aerosol generating procedure. It's important to simulate these emergencies of an unexpected intubation for a COVID positive mom and figure out with your teams what to do. And here is kind of our delivery complication simulation. And so this is a simulation where anesthesia and the entire nursing staff is waiting just outside of that room. We're trying to limit the number of people in a COVID positive room, and in a negative pressure room, you can't just open the door and call for help. And so we stock the ante room with everything that you possibly need. We have a runner whose entire job is to run back and forth and grab things. We also have a gatekeeper to act as a liaison between the room and the outside. We have to figure out how to communicate within the room. And then with anesthesia going into the room, you have to think about all the supplies that you need that are available in an operating room, which is not typically available. And then we actually had our anesthesiologists run in the ventilator and run in all of the anesthesia required carts and everything to make sure that it actually fits into the space, because that's the problem, is that there's a lot of equipment that you need operating in a space that you may not be used to. And this is just a quick video kind of simulating intubation and what the rest of the room, what the rest of the team needs to do. How does the baby exit? This is another part of simulation, kind of thinking through, here's our peds team simulating, handing off the baby, where the isolette comes in, and how to get the isolette in and out of the mother's room. We have a lot of other areas where we also had simulation, thinking through what the best way of all of these scenarios are. We had delivery scenarios in the COVID ICU unit and delivery scenarios of a COVID positive mother in the emergency room as well, which was very helpful and required lots of teamwork. And with that, that's all I have to say about how we prepared our labor and delivery units. And I will turn over my presentation here.
My name is Mihaela Podovi. I'm an anesthesiologist fellowship trained in obstetric anesthesia. I work at the Brigham and Women's Hospital. We are a tertiary academic medical center affiliated with Harvard Medical School. I have been serving as the QA/QI director for obstetric anesthesia division since 2017. This January, I was closely following the media reporting on the coronavirus situation in China. I was concerned, but it wasn't until the Italy's outbreak at the end of February, around February 21st, 22nd, that me and my colleagues realized that we really need to get ready, and this outbreak is going to affect us. So we started preparing. We created protocols based on the available recommendations from the CDC and the WHO, and based on the available published reports from China. Needless to say, the protocols changed multiple times, constantly being adjusted based on the new information coming out. As the number of local cases started to pile up, our experience grew and our plans changed. Early in the pandemic, I registered and listened to webinars from South Korea, China, Europe. I wanted to learn from the frontline healthcare workers as much as I can. I found them extremely helpful, and I am honored to take my turn today in talking about the SOAP considerations for obstetric anesthesia care in COVID-positive patients. My division chief is Dr. Bateman, and in early March, he thought that others may find our unit's preparations helpful. So this is how the SOAP interim considerations were born. Our and other SOAP members' opinions during these early preparations were used to compile a list of suggestions. The SOAP considerations are expert opinions. They are designed to provide general guidance. They are in line with the US CDC and WHO guidelines. But you should use all available information so you can create your protocols that make sense in your local environment. SOAP is not the only society that put out guidelines for care of the COVID patient. Society of Maternal Fetal Medicine, ACOG, CDC, they all provided expert opinions guidance. And these are the links you can log in and take a look at them. Specific to our maternity units, these are the general objectives we had. We want to provide good care for the mother and the baby, but we also want to keep everyone safe. Our staff, our mothers, their families, the infants. We need to continue to provide safe care, to continue to have the trust of our patients. Changes in practice in the light of COVID-19 should consider the level of the community spread, should consider the availability of testing and the personal protective equipment available. Hard decisions like prohibiting the visitors or family members support for laboring women, separating the infant, deferring in-person care, they all need to be carefully considered. They all have consequences. So what did we do? It is important to have a plan. Ensure that all your staff knows the plan. In addition to doctors, there are many more people involved in the care of a pregnant patient. We have the front desk staff, we have the lab staff, the ultrasound staff, nursing aides, cleaning and transport people. So you have to keep everybody in mind, and you have to think of them as you decide what's the safest practice in your environment. The pictures below are just the OB anesthesia division's flow charts for different scenarios. So we thought about what would happen if a patient comes in through our triage and needs a procedure. Is the procedure urgent or not? What if the patient is in the unit and needs a delivery? Is the patient stable or not? Who gets notified of a case? Who does? What OR we go into? Who sets up the OR? Where are all the things we need? These are questions that need to be answered in advance. Put them down on paper in an easy to follow format, then distribute and get the feedback from your staff. To keep everyone safe and to limit the exposure to infected people, you have to assume that everyone entering your facility carries COVID. Carries the virus, the SARS-CoV-2 virus. Identify and isolate the sick makes sense, and symptom screening is important. But unfortunately, this virus can spread before someone knows they are infected. So if you assume everyone entering the facility is carrying the virus, you can be prepared. To limit the exposure, actively screen everyone for fever and symptoms, and turn away symptomatic people that do not need to be in the institution. So no sick visitors, no sick staff, no sick patients, unless they need medical care. This will limit the hospital transmission. Other ideas that our institution had was, and actually a lot of institutions across the globe had, was limiting the points of entry. If you want to do screening at the doorway, you can't have a lot of doors to come in. We installed droplets barrier, so all the front desks have plastic screens to protect the person behind the desks from droplets. And we have everyone wearing a mask. CDC refers to the universal mask wearing as source control. So if somebody is an asymptomatic carrier but wears a mask, the risk of infecting somebody else goes down. There are limits to universal mask wearing. Obviously, a patient that's incapacitated, unconscious, or is short of breath cannot wear a mask. If somebody screens in for COVID, we isolate, we give them a mask, and we test. And we want only people that have appropriate PPE to provide care. And we want to minimize the staff involved. Pre-hospital screening is ideal. So as much as possible to avoid unprepared and unprotected contact, patients should be called in advance or they should call in. Turning towards the OB anesthesia care, if a patient is SARS-CoV-2 positive or it's a person under investigation and needs anesthesia care, a few general principles should be followed. Donning and doffing takes time. Safety of our staff comes first, and there is no emergency in a pandemic. And this is hard, right? Like, we are used to running in for emergency cesarean sections and for hemorrhages, but we cannot make mistakes in this COVID times. So you have to think of the best way to minimize the time to respond while fully protecting your staff. So some of the changes and some of the things we implemented include minimize the number of staff involved in care, prioritize experienced providers. So I will not take in a trainee that I need to supervise. It doesn't make any sense. If there is a procedure to be done, I'm just going to go in, do it myself. And then maintain a log that would facilitate contact tracing. And then rethink your staffing model. So for our unit, that meant having somebody on backup call at home that would be able to come in to cover the unit if the primary attending on call is doing an OR case in a COVID positive patient. Before COVID-19, all our pre and post anesthetic checks were physical in-person visits. Now we use the phone for many of our visits. We call into the rooms to ask questions and provide reassurance, and we assess over the phone if an in-person contact is necessary. As with every emergency scenario, the best way to learn is by simulation. And I recommend simulating different scenarios in your work environment. Lesson will be learned by facing the real situation, but simulation will hopefully increase the comfort level, and we add and will teach you lessons when you have to deal with the obstacles that are added in terms of wearing PPE and not having things in the usual places that you're used to. Seeing through face shields that fog up, hearing through layers of PPE, having the N95 on for long periods of time are new experiences for most of us. And the best way to know how it feels is trying it when there is no risk. I do acknowledge that PPE is on shortage and you cannot afford to waste it, but also PPE can be reused. So you can afford to test it and then reuse your PPE. I think that would be an ideal situation. The advice we gave everyone with the SOAP's interim recommendations was to anticipate and prepare. Do not put yourself in an emergency situation that could have been prevented. A good working epidural will avoid the need for an aerosol generating procedure later on. If the epidural doesn't work well, have a low threshold to replace it. Have a low threshold to move towards delivery in cases that have a high potential to become an emergency. If a patient that is pregnant is in respiratory distress and it looks like it's getting worse, don't wait until it becomes a stat situation for either the mother or the baby. So anticipate. SARS-CoV-2 spreads through droplets, and we were concerned about the risk of compromising the cabinets and the drawers that would be open during the care of a patient with COVID while in the room and in full PPE. Depending on the setting, there are some things that need to be brought in. For us, the labor rooms, we would need to bring medicines, so our drugs in if we go into a labor room for a placement. So at my institution, we figure out what's the best way we can go around this concerns. So for the ORs, in the ORs, they taped the closets and the cabinets, and they covered everything that has a drawer, and then they created these buckets with things that they may be needed in different scenarios. So we created kits and checklists with what we would need to bring in different scenarios. And we have checklists and kits for epidural placements. We have cesarean delivery kits. We have cesarean delivery drugs and boxes and trays. We created visual aids and for a workflow. So if somebody goes in to do an epidural, they would look quickly at a checklist or a workflow to make sure that they're not missing anything. And then we have visual PPE donning and doffing checklists. The personal protective equipment recommended by the WHO for the care of COVID patient is droplet and contact precautions. So you would need a gown, a mask, like a regular surgical mask, face shield and gloves for routine care. You would need added airborne precautions, meaning an N95 or a PAPR if aerosol generating procedures are likely. My healthcare system considers intubation, extubation, chest compressions, CPAPs, nebulization as aerosol generating procedures where the N95 is required. When talking about putting the personal protective equipment on and taking it off, the best advice I have is use observers and checklists. And then doffing is more critical than donning. This is when you risk contaminating yourself. We double glove, having clean gloves on the outside. If they get blood on them or if they get grossly contaminated, makes it easier to take them off and still be protective. We discovered the importance of a runner. A runner is a person outside the room that is there to get you what you need so that you don't have to doff to get out of the room for little things. And then what we discovered is there than one way to communicate into a room. We use iPads, we use baby monitors, we use phones, but room phones do not bring personal phones into COVID rooms. If you go into a labor room to place an epidural, we ask the patients to be masked. Like I have a patient wear a mask if possible, if it's reasonable, and everybody else in the room wears a mask. And we have splash protection, we have face shields. And for non-aerosol generating procedures, I think that is appropriate in preventing transmission of SARS-CoV-2. We try to bring in everything and minimize the door opening. We suggest checking platelet counts and checking anticoagulation timing. If the patient has been on anticoagulation, timing for epidural placement becomes relevant. We double glove, as I said, and then we stay in the room longer than before COVID. So I wouldn't leave a room until the patient is comfortable and the patient is stable. What I don't want to happen is take everything off and then waste PPE because I have to come in 10 minutes to address a situation or a question. If a case requires general anesthesia, recommendations for PPE include airborne precautions. We try to minimize the number of people in the room, and we try to minimize the number of people within the 6 feet of the airway. We try to maximize the chance of success by having an experienced provider, by using video laryngoscopes, by having good head positioning. We use HEPA filters to protect the anesthesia machine from contamination. We try to avoid situations where high flow oxygen is used, so avoid nebs, avoid bag mask ventilation, aggressively combat nausea. The picture on the right is created by one of our residents. So he made this flow chart or infographic to be used by the airway team. So this is what you would look at before you go in to do an airway in a COVID positive patient. And you have somebody read through to make sure that you're not missing anything. We try to minimize droplets during intubation, but extubation, as you all know, is a critical time. To minimize droplets on extubation, we came up with different ways. We use propofol, Lido, Remy before extubation to ensure a smooth extubation if possible. We use plastic drapes to kind of limit the droplets. We have a surgical mask readily available to put on the patient right after extubation, with the caveat that if the patient is sleepy or nauseous, this is not going to work. For PPE shortage, we all have PPE shortages, and we started this being really worried about the availability of N95 masks. So what we did, we thought about what can we do to preserve and protect our PPE. So we got guidance into N95 extended use versus limited reuse. We have N95 decontamination solutions. We reuse shields. And then I'm sure you all saw intubation boxes. That means intubating under plastic drapes that would minimize the droplets. We have people printing face shields at home using 3D printers. But one of my favorite innovations is using the snorkel mask with a HEPA filter for airborne protection. So these are two of our residents that thought of this, that got this mask tested to make sure that it's good enough for airborne precaution. And they have a website and a nonprofit organization that sends masks and filters to anesthesiologists that do not have appropriate PPE. We're all in this together, and we can defeat this if we learn from each other. So thank you.
Good morning, everyone, and good evening to the other side of the world. Now, the past three speakers have actually made my job simple. They have given an approach of this complex situation. Now, I actually highlighted unforeseen and complex problems in my title because this is by surprise to all of us. And next, it is a very complex problem and that doesn't have a simple solution. Now, my job here is to come up with a very practical, simplistic approach to this complex problem after listening to the three speakers. Well, I have no financial disclosures except that I do have a website on painfreebirthing.com for patients' education for labor analgesia and other forms of analgesia. And I also maintain a fairly big website on capnography monitoring. Now, I have to make three comments at the outset. The approach may differ based on the resources of every institution and country. Now, what is possible at some institutions may not be possible at others. However, the basic principles are same and these apply to all. But what is available plenty at all places at all over the world is clinicians and healthcare providers with great skills. Secondly, the creativity and ingenuity of the teams, like creating their masks, barriers, and shields to counteract the situation we face. And we have to be adaptable to a new system. Now, the factors that are relevant to COVID-19 in obstetrics is no electives to cancel, the work goes on. Protect other patients from known or unknown pregnant patients. And this is what is very important for us. Protect healthcare personnel, particularly for stat interventions. Now, one thing we have realized here is there is a variation in the spectrum of presentation of COVID-19 cases in pregnancy. Now, we went through about 21 patients in our system, and planning has to occur at all levels, has been pointed out. And particularly, this is very important in small private practice groups. Now, how it is done is dependent on the local factors and the prevalence of COVID-19 in that particular area. Now, as pointed out early, that every institution adapts to the requirement. And this, as you can see, a barrier with a door was built in 4 hours after we consulted with the engineering department. The reason I'm showing this is it can be done if you use all your resources at your institution. And this barrier actually isolates 2 rooms which are negative pressure. And then, of course, there is an area of donning and doffing. Now, sometimes the both rooms are not sufficient when you get more than 2 patients. Then we subsequently used other rooms, but try to be as neutral as possible in the airflow. Now, adjacent to that, of course, we have all the equipment that is ready to go, as pointed out. And this has to be done, before expecting any cases. And we were a little fortunate that we had enough papers actually that was provided to us, and they were already ready to go at the entrance of those particular rooms. And this is inside room of a labor and delivery, and which is actually everything is arranged to receive a patient, and where a stat cesarean section can also be done. Now, we have also earmarked some operating rooms, designated operating rooms in 1 floor above. And in the main operating room, 2 rooms to receive patients from the ICU, because it is easy to transport patients from the ICU to the main operating rooms on the same building. We also made some plans within the operating room where the ICU ventilator, if you are planning to use, will be stationed between the bed and the anesthesia machine. So you pretty much earmark all your plans. Then, of course, there is a designated biocontainment ICU unit where we have to make provisions for a stat cesarean deliveries, neonatal resuscitation bay if a cesarean section is done there. And therefore, the cesarean section equipment must be always at hand in the ICU, and a group communication system has to be established. for a stat delivery. That means every concerned group gets the delivery notification to go to the ICU immediately. And of course, each case is followed by a debriefing to improve the system. We also made some COVID boxes for labor analgesia as well as for general anesthesia containing the necessary drugs. And please, I need to emphasize that these boxes are not disposable. Once the drugs are used, we actually clean the boxes, clean the drugs and put back, and the pharmacy restocks it. And this is, of course, a small airway kit ready to go. Now, you must have some sort of a simplistic approach in the labor and delivery unit to enable the flow. Every patient, of course, here is tested and in a designated area in the pre-op, in the triage, and by a nurse who has an N95 mask, etc. And if an intervention is required before the results, a labor epidural is placed in the labor and delivery room designated for the COVID. And if there is a anesthesia is required for a stat cesarean section, we generally use an N95 mask and a face shield because there may not be a time for a full pampers. If the COVID-19 test becomes positive and the patient goes to the negative pressure room and a labor epidural is placed using either pampers or an N95. If the COVID-19 test is negative, the patient goes to a regular triage room, and we have been using N95 with a shield just for just to protect ourselves, because as Arvind Palniswamy pointed out, that the labor, particularly in the when they are hyperventilating, it could be an aerosolizing circumstances. If the COVID-19 test is positive and the patient is unstable, the patient actually goes to the designated ICU. Now, before sometimes transferring this patient to the ICU, we may actually intubate this patient in our operating room, the designated operating room, and then take the patient on an ICU ventilator with the HEPA filter to the designated ICU. Now, the positive rate is roughly about 4% in our institution. And this testing actually enables us to use our resources little more appropriately, particularly in the shortage of PPE era. Now, the flow pathway may also help in using our PPE resources carefully, as I have just mentioned. If the status is unknown, could an alternative system using some logistics work here or not is a question that needs to be discussed, like asymptomatic patients, no travel history, green zones, etc. But again, Dr. Arvind Palniswamy has pointed out that asymptomatic carriers do exist in pregnant patients. Now, we have taken care about 21 patients here. And the first group is very simple. And this is what many institutions are going to see. Vaginal delivery without epidural can occur. Vaginal delivery with epidural, no problems. Vaginal delivery under CSC. And then one cesarean section delivery under CSC. So this particular group will be the common one at majority of the institutions and probably in many institutions. However, COVID-19 in pregnancy is not that benign. Probably our institution is a little bit of a high-risk center. University of Maryland Medical Center is a high-risk referral center. Probably that is why our incidence of patients on ventilation and ECMO is about 43% out of this sample of 21. And 3 of them had cesarean sections so far. And 1 was an urgent cesarean section. So we had time to move the patient to a negative pressure OR. But 2 were stat cesarean sections in the ICU, and they were moved to negative pressure OR for abdominal closure, because this patient actually had a lot of diarrhea And as you know, that diarrhea is one of the features of COVID-19. And therefore, this patient was taken to the operating room for abdominal washout and closure. The reason for stat section was there was a self-extubation and reintubation desaturation that resulted in fetal bradycardia and cesarean section. And one patient actually delivered vaginally in the ICU on ventilator itself. This is a good news here. 18 patients were discharged home. One readmitted to another hospital on oxygen, I believe, and 2 are in-house, and one of them is actually currently in prone position. She is 25 weeks pregnant, had an interval cholecystectomy, and the oxygen requirement went up during anesthesia, and she was a COVID positive too. So she is currently on ventilator, and she is actually on prone position because our last FiO2 was about 80% and PaO2 was about 85. Now, one patient was on ECMO, and she was a transfer from outside hospital, and patient had HELP, had a cesarean section and COVID-19 and transferred here. Patient went on to ECMO and finally actually she died. Now, we do not know whether it was a HELP or it was a severe COVID-19 that resulted in thrombocytopenia. But a complication of pregnancy on the top of COVID-19, I think we have to be extremely careful. Now, this flow demonstrates one point. If a center is not capable of handling these patients, and if they happen to see a patient who is likely to be symptomatic and requires an increasing oxygenation, I think probably efforts have to be made to transport this patient to a center that can take care of these patients. Some of the key observations I would like to emphasize. Now, there was ICU stat sections, as I said, and to understand why an ICU stat section may occur, you have to go into the physiology of the uteroplacental blood flow. Approximately 25 ml per minute of oxygen is required by the uteroplacental unit. And we have about 150 ml per minute of oxygen is delivered to the uterus, and this is the oxygen plus. So there is large amount of buffer in normal pregnancy. And when there are pulmonary infiltrates and respiratory compromise in COVID-19, the oxygen flux could be at a lower margin of the buffering threshold, and it is precariously balanced. And any variation in oxygenation and cardiac output decreases the flux, and therefore the patient can have the fetal deoxygenation is decreased and fetal bradycardia and can result in cesarean section. So we have to be extremely careful when we induce these patients, particularly in the ICU, for intubations. Now, pre-oxygenation becomes extremely important when there is a respiratory compromise in pregnant patients. And this is a small device which actually it is a modified Mapleson-C that allows us to give 100%. And if you put a filter between the mask and the bag and the sampling end-tidal CO2, we should be pretty good in giving 100% oxygen in preparations to avoid apneic desaturation during intubation. The other key observations are most of these patients was induced with ethomidate. If you are using any other drug, make sure that the patient is cardiovascular stable. Succinylcholine was used for intubation, and rocuronium to maintain, and propofol and fentanyl were used as sedation. The ICU parameters for respiratory rate was generally 16 to 26, tidal volumes were 350 to 400, a PEEP of 10 to 16 centimeters, semi-prone or prone position as permissible by the abdomen was used in these patients. And the PaCO2 was maintained between 34 and 38, and the end-tidals were 32 to 38. And therefore, the arterial to end-tidal difference here normally is 1 millimeter, was only 4 to 5 millimeters here. So the end-tidal does serve as some guide to the arterial PaCO2 during ventilation. The pH was 7.4. HEPA filter was used on the expiratory port of all ventilators. The other key observations are overall pregnant patients did well. despite going on to ventilation. Pregnancy by itself probably is physiologically adaptable to take stress. Some observation is the fibrinogen was slightly elevated to almost up to 994 if you look at the range, whereas our normal range is about 268 to 620. And the D dimers were also elevated, and some of the patients on ventilator had high D dimer values. Platelets were in the range of about 400 mean and 226 to 640. And 5 of the ventilation patients, as I said, had D dimers greater than 2000. Now, these platelets can become low as COVID-19 becomes severe, and Dr. Lisa Lifford will highlight that in her talk. The medications that were used in these patients are no treatment in asymptomatic patients, to a combination of antibiotics like ceftriaxone and zithromycin. Hydrochloroquine was used in one patient, and remdesivir is a trial center for this drug. When we give regional in COVID-19 parturients, some form of PPE must be used. As Arvind pointed out, that we did a study when we found out that the minute volume during labor increases almost beyond 25 liters per minute. So it could be an aerosolizing circumstances. So N95 mask with a face shield is most commonly used, and the face mask on the patient, as Dr. Podovi pointed out, and non-rebreathing oxygen mask is indicated as needed, and this is not an aerosolizing generating equipment. We use remote iPads for checking these patients so that we don't have to go into the room, and some form of communication can be established at other centers depending upon whatever system they seem to use. And this is our iPad system. We actually interview the patients using iPads, and most of the vital data from the rooms comes to our call room. So we pretty much know what is happening in each L&D room. Neuroaxial for cesarean delivery seems a very good option because there is no aerosolization at least. And pregnant patients with COVID-19 seem to tolerate well. Hemodynamically, they are stable. And actually the sections we did, they were very, very stable. But one thing I would stress is a good documentation of the neurological status of the patient should be done before administering neuroaxial block in these patients. Then patients should have face mask and oxygen mask as indicated. General anesthesia in ICU, if we did a general anesthesia in the ICU, we just continue on the ventilator and we were present with the PPE. And general anesthesia in OR, we use either PAPRs or the N95 as the circumstances can be with the face mask and shield. And if the patient is an ICU ventilator, we continue ventilation with the ICU ventilator during transport from the ICU to the OR and also intraoperatively. So it avoids disconnecting the patient from the ventilator. And of course, always HEPA filters should be in line. There were no issues with the hemodynamic stability, although they had respiratory compromise on ventilator and prone position, but hemodynamic stability was there in most of the patients. And there is always a debate and there is always a short supply of this equipment, and they're all reusable. In fact, I have used my N95 mask multiple times and I clean them and keep it. And as Dr. Podovi pointed out, that they also recycle these masks if we give it to them overnight and they give it the next day. All are reusable. I'm just stressing on that. Now, COVID-19 has taken all of us by surprise as far as the PPE is concerned, because we never had so much of equipment. Naturally, there's a lot of commotion on PPE availability. When and what to wear and who should wear is an evolving process, and changes occur every day. And considerable thought has to go into this process at every institution. And as I said, necessity is the mother of invention, and and clinicians are coming with varying ways of protecting the healthcare workers during this pandemic. So what is my summary? No single strategy of anesthesia is the final approach. All depends upon how the parturient presents to us. Regional is the way to go where feasible. Caution in parturients with a respiratory distress. If you are giving regional in a patient, in a parturient with a respiratory distress, the respiratory compromise may deteriorate and an emergency intubation may be needed. So this has to be a judgment call on the part of the clinicians. Patients on ventilator will have IPPV continued on the ventilator. General anesthesia where the fetal indication of urgency is there. So we do give general anesthesia for stat cases if it is indicated for the fetus. And general anesthesia precautions, general precautions of the COVID-19 that are currently enforced in any institution must be followed. And be safe and protect others. And the last but not the least is common sense should prevail in our final how we manage these patients safely and also keep ourselves safe. Thank you.
So it is my honor to speak in the last few minutes of this important webinar after my wonderful colleagues. And I'm going to take a few minutes to talk about some special considerations. Two of them, thrombosis and thrombocytopenia, which both have an impact on the prognosis and outcome of our COVID-19 patients, and also on our ability to do what is usually our preferred anesthetic, neuraxial anesthesia. And then I'd like to introduce you to our soap delivery registry. And I'm going to admit in advance that I'm very much hoping for some international collaboration with you. So first, thrombosis. So the COVID-2 coronavirus-induced infection we know is associated with coagulopathy. And in fact, as part of regular coagulation test screening for patients with this disease, it now includes the measurement of D-dimers and fibrinogen. The initial coagulopathy, these are the elements that are usually abnormal. It's unusual to see abnormalities in the prothrombin time, the partial thromboplastin time, and the platelet counts, although these can certainly be abnormal later. The pathophysiology that's underlying this is really poorly understood. There is some generalized endothelial dysfunction. There certainly appears to be a pulmonary specific vasculopathy. We know this is primarily a pulmonary disease, or at least initially a pulmonary disease. And there's even a new term coined called pulmonary intravascular coagulopathy, or PIC. Elevated D-dimers have been shown to be correlated inversely with survival, and ethnicity, which has really come out as a key factor in COVID-19, has a major effect on thrombotic risk. In fact, threefold lower risk in Chinese compared to Caucasians, and a significant higher risk in African Americans, much as we see in thrombotic disease in general. And then some early and promising results that we see in terms of low molecular weight heparin, at least in some studies done with Caucasians, rarely developing DIC. This is an interesting study which I will present to you because the data was published and then reanalyzed and published again. And I am going to give you what we call the punchline, or the take-home message of this study. These 184 sick ICU patients with COVID, non-pregnant patients, all received pharmacologic prophylaxis. They had a lot of thrombotic events, primarily pulmonary emboli. And these numbers of thrombotic events increased the longer they were in the ICU. And the data for anticoagulation looks good. Decreased hazard ratio when they were on not full dose anticoagulation, but thromboprophylaxis. The data for those who had clots looks bad. The cumulative incidence of death dramatically increased for those who had these thrombotic events. So what do we do clinically? These are recommendations. They're small, but they can be found online from the International Society of Thrombosis and Hemostasis. And I direct your attention to the right side, which is green. These are the cases where the D-dimer levels are not markedly elevated. And these patients are really flagged as much lower risk, particularly if they're doing well. You worry about them a lot less for thromboses. The patients where the blue boxes or purple boxes are, these are where the D-dimers are markedly raised. And to some extent, the prothrombin time may be raised. There may be thrombocytopenia and decreased fibrinogen. These are the patients where even if they don't look clinically sick, you need to worry about thrombosis, admit them, and start low molecular weight heparin. So what do we do with our obstetric patients? Well, when you're talking about obstetric patients that don't have COVID, and you're just trying to decide what to do with thromboprophylaxis, we have a lot of protocols. We have ones from the Royal College and from our American College of OBGYNs and chest surgeons, and we have them from Australia, and new ones from each of our institutions, and they all say different things. So it's probably not a surprise that, and this kind of cute study showed that even for women who don't have COVID, when you're talking about pregnant women, if you take this same 300 women and try to decide what kind of prophylaxis they should have, depending on whose recommendations you look at, you can have everything from 85% to 1% of the women, the same women getting prophylaxis after cesarean delivery. So I don't think it's going to be a surprise when I tell you that we don't have clear guidelines of what to do with pregnant women and thromboprophylaxis in the face of COVID-19. There is a call that we should have thromboprophylaxis. If you're in the United States, there are some guidelines that say if the delivery is imminent, perhaps, and you have unfractionated heparin or IV heparin available, perhaps think of those that can be taken away more quickly. And if you're on low molecular weight heparin and it looks like there are signs of imminent delivery, think about holding the dose. What we are very lucky to be able to say about our pregnant patients is their risk of epidural hematoma is low compared to other patients. And this is very important because we like to do our neuraxial anesthetics. There is very little data about the pharmacokinetics of these anticoagulants, heparins, in our pregnant patients, but the small amount of data that's there, and this is one of the often repeated studies, shows that the effect of a low dose of enoxaparin on anti-factor Xa levels, the higher curve is the anti-factor Xa level in a non-pregnant patient. The lower on a pregnant patient, less of an effect. And there are guidelines. These are the SOAP guidelines that help you know how long you need to delay your neuraxial anesthetic, depending on how much and when a pregnant woman got a dose of low molecular weight heparin. All this is to mean that one shouldn't be afraid of using these anticoagulants to help our pregnant patients. And also, you can restart the anticoagulants even if the pregnant patients have gotten neuraxial anesthetics. And there are some complexities to deal with, which I won't get into right now. So what's the story about thrombocytopenia and COVID-19? Again, something that's important for prognosis and something that's important for our neuraxial anesthetics. This is a complex chart that talks about all the possible mechanisms of thrombocytopenia in COVID-19, but I'll draw your attention to a couple of important things. Many of the things that you've heard my colleagues talk about can lead to thrombocytopenia in COVID infection. Cytokine storm, direct infection of the bone marrow cells, autoantibodies, and even lung injury. And these can lead to all of the mechanisms that you can think of that would decrease the platelet count, decrease production, increase destruction, and decrease circulating platelets. So what does the data show? Well, we've heard a lot about the association between thrombocytopenia, particularly with severe coronavirus, COVID-19 infection. This was a meta-analysis, 9 studies, almost 18,000 patients, 22% of them with severe disease. And in fact, it showed that thrombocytopenia can be a problem, particularly in patients with more severe disease. Even lower platelet counts was correlated with mortality. However, if you actually look at the numbers, platelet counts of less than 100,000 were very rare overall and occurred only in those with the most severe diseases. Not to say that this isn't an issue for the patients themselves, but when you're talking about caring for these patients, these were highly unlikely to be patients that you were thinking of doing neuraxial anesthetics in. This is a case report that recently came out, a single pregnant patient with COVID-19. She had symptoms of a cough and a fever, but not particularly critically ill. However, her baby was not looking like it was being well oxygenated with its placenta, and she needed an emergency delivery under spinal anesthesia, which she got. Afterwards, her laboratory values came back and her platelet count was 24,000. And this raised the question, do we need to worry that there are a lot of the others of these women out there? I would say a couple of things. One is many times we will routinely check a CBC or at least draw a platelet count from a pregnant patient when she comes to us. These may be the patients that we actually wait to see the platelet count before we do a neuraxial anesthetic. However, this is a single case report, and it is highly unlikely from the data we've seen thus far that we're going to see a lot of women who present with mild symptoms and platelet counts in the range under 70,000, where we begin to wonder. I'm going to take the last couple of minutes to very quickly introduce you to our SOAP COVID-19 delivery registry, and I very much hope that we can find a way to work together. The goal of our registry, my guess, is similar to the goal of your registries, which is to really capture the variety of presentation, complications, anesthetic techniques, and obstetric outcomes associated with this very difficult infection. We decided for the first piece of this registry to really focus on patients who were delivering with COVID because it's such a heterogeneous group in the first place. And we added controls so that we could have a good cohort study. We have 15 sites across 15 different academic centers across the United States right now, many more institutions, and a good geographic representation, and at least 500 patients who actually delivered with their COVID infection within 2 weeks. And we're looking at a host of obstetrical outcomes as our primary outcome, a composite neonatal outcome, and have descriptive analyses on anesthetic outcomes and a number of other things. And our goals for these next steps are to not only increase the participating institutions within the United States, but we'd love to form partnerships across and internationally. We have some ideas for expanded data elements. When we put together this registry, we knew very little bit about COVID-19 in pregnancy and to plan for future investigations. Most of the data that we've presented today are on very small numbers of pregnant patients, and we really look forward to working together to increase the power of our observations. We know and hope that you have very many questions and things to share with us and teach us. So out of respect for time, I'm going to stop there.
So a wonderful series of lectures, and my thanks to all the speakers who were able to put this together in such a short span of time. Before we conclude at least the lecture component of this webinar, I wanted to emphasize 3 maxims that people can walk away with. First of it relates to the actual science that was presented. We need to understand that it's constantly evolving. So we need to strive for weekly knowledge updates because what's true today may not be true in a month's time. So please keep an open mind with healthy skepticism. The second relates to the delivery of care. I know that we presented data from the United States, but I know that that's very heterogeneous in India as well as other countries. So I think the way you deliver care should be context sensitive and institutionally feasible. So please take stock of all the resources that you have, both material and personnel. Be creative, but do not compromise because patient safety and provider safety both are equally important. And please do simulation drills for proper donning and doffing of PPE, which I think is very critical. You don't have to use PPE to do it. You can just pretend that you have all the equipment available and pretend to do it. And finally, some of the basic principles, which most of the speakers alluded to, provider safety is paramount. And please remember the phrase that no emergency in a pandemic. It doesn't mean that we cannot do stat C-sections. What it means is that it should initiate a conversation even before a situation evolves into a stat section so that you can prevent that from happening in the first place. And if it does happen, you should actually take your time to ensure that everyone is safe. So definitely preemptive deliberation to avoid disappointment. And one of the most important things is to put your egos aside. This is all about patient care, patient safety, and provider safety. So with that, I would like to pass on the podium to Dr. Tangiwat from Thailand, who would be providing the thank you note, following which we would kind of slide into our question and answer session, which is probably going to be the most productive because the providers are located in different institutions with different setups, and they all have a lot of anxiety on how to provide care. So I think that'll be one of the most useful components of this webinar. I will start bringing up the questions. So one of the first questions, I have a total of 1,500 questions to curate through. So what I've done is organized all of them into specific themes, and I apologize if I don't get to your question. It is going to be very difficult. So one of the first questions is about how do you ration the use of PPE and ensure safety of providers? And I'm actually going to pass this question off to two people in the panel first. It would be Dr. Reena Wani from Mumbai and Dr. Sunil Pandya. Maybe Dr. Reena Wani, you want to take a shot at that question, followed by Dr. Pandya, and then we'll have input from Dr. Shunsuke Hyuga from Japan.
Good afternoon, friends, and it's a pleasure to interact with all of you. And as beautifully said by one of the speakers, across the globe, the problems are the same. So what was mentioned right at the beginning, obstetrics and gynecology is always, I would say maternal and child healthcare is never given the priority as it would be in the emergency room. So with the numbers, I am speaking as of today, we have dealt with 150 plus COVID positive women who have come to a hospital, which is a non-COVID hospital. So proper COVID positives do not come to us, but following the ICMR guidelines of screening, we have found that a significant number of women are positive. So how do we use PPEs? So we have also evolved, as was beautifully pointed out in the slides. When we started off, it was, oh, you have too many cesareans. How can we use so many PPEs for you guys? Manage with surgical masks, manage without face shields. So we evolved. We started making plastic face shields by the microbiology department using overhead projector plates. And we started doing it in that way. Along the way, we found that we had one of the speakers mentioned that consider that every patient can be potentially positive. And we have now reached that stage where we have decided to be safe, use the PPEs rationally with levels of protection. The most important is ensure that all your healthcare providers, and it's a team approach. It is not just the operating surgeon. It is also the anesthetist. It is also the servant who is removing all the PPEs and carrying away all the stuff. It is the nurse who is also inside the OR when GA is being given. So we are rationalizing the use of PPEs and trying to ensure that everyone is safe. Having said that, I'm sad to say that in this journey of 2.5 months, we have had 3 of our healthcare providers turning positive, especially in the initial part when we were not able to use PPEs in the correct manner. So we have learned that we have to, yes, we have to ensure that we do well. And as beautifully put by Dr. Bhavani, that there is no emergency in a pandemic. One of our anesthesiologists probably became positive when in an emergency he had to intubate a patient in casualty and he did not have the PPE, or he did not even have a face shield. So friends, I would like to tell you, please use whatever you have available, be safe, and be logical in your approach. And this is something which is not going to change overnight. We have to change the way we practice. That's my
Thanks, Dr. Vani. Dr. Sunil Pandya, do you have any quick comments on the topic?
Yeah, good evening all this part of the world, and good morning to the people from the West. Greetings from Association of Obstetric Anesthesiologists India Hospital. Just to give a brief intro of our hospital, we are a 300-bed tertiary perinatology center with annual delivery rate of about 10,000 deliveries per annum, and epidural take rate of almost about 55 to 60%. And incidentally, last 2 months statistics, a 5% spike in epidural acceptance rate was seen. So with this, coming back to the question of use of rational use of PPE, what we have done in our hospital and protocolizers, we have graded the severe rate of exposure and the AGP, aerosol generating procedures, and the use of equipment. So at the time of PAC, we just use, we recommend the use of goggles, face shield, and a 3-ply surgical mask is fair enough. Even if you are doing a procedure like labor epidural or a spinal in category 2, 3, and 4, I'm not talking about stat cesarean sections, but category 2, 3, and 4, if you are doing regional anesthetic in an uncomplicated patient, asymptomatic carrier or a suspect, we recommend the use of goggles, face mask, face shield, and a surgical gown, not a complete PPE. But if you are involved in a stat cesarean section and you're going to intubate, or intubation chances are likely, or a patient is a short statured where patient may develop, as Dr. Bhavani pointed out, patient comes with a respiratory distress and high chances of having during a surgery, then yes, donning full PPE is mandatory. It is important, especially in this part of the world, because there is a constraint, unlike the West, and we also have a policy of reusing N95 mask at least for about a week's time, so that the cost can be minimized.
Thanks, Dr. Pandya. Dr. Balavenkat, do you have any comments?
No, I actually thought in centers or in countries and provinces where they're in the green zone, where there is a virtual threat of COVID, but really it is not existing. So I think probably there should be a note of caution. The reason I'm telling this is in few centers, they refuse to give anesthesia to a pregnant patient, and she was with the fear that they didn't have an N95 mask and how to start a case. And then eventually it resulted in both fetal and maternal death. So the point I wanted to put across is I think individually the decisions have to be taken. And when in cities and areas where the prevalence is very less, I think N95 may not be really required to put an uraxial block. People may still go with a 3-ply mask, and if need be, the face shield, which we have. Thank you.
Great, thank you. So the next question, it's actually really insightful, very intelligent question. So this is coming from, I guess, someone from a low resource setting where they do not have access to SARS-CoV-2 testing. So the question is, can you use a combination of lab markers that would increase the likelihood of identifying a COVID-19 patient, especially a combination of lymphopenia and maybe D-dimers? I think this is a great question, and I think this would be relevant to a lot of practices. I'm just going to open this question up to all the panelists. and we'll see, we'll kind of navigate our way through. Dr. Sunil Pandya, do you want to take a shot at that question?
I must tell you that my exposure to COVID-19, unlike Dr. Rita Vani, is about 7 cases who are positive, and all of them are asymptomatic carriers, and incidentally, they picked up because of the contact history. And incidentally, none of the patient had lymphopenia or thrombocytopenia or any signs of respiratory distress. And one thing that I have realized out of experience and reading and literature and sharing from others is bedside ultrasound in doing an ultrasound of the lung is quite sensitive to pick up if the patient has mild respiratory distress instead of radio imaging or a CT scan of the chest. But lymphopenia and thrombocytopenia in asymptomatic carriers are very, very rare. So if you ask me, in a low resource setting, going by the current trend, in India to date, almost about 600 plus deliveries have been reported in COVID patients, and 2 patients have succumbed. But of this 600, we don't have the entire hematological data. It will come probably in a couple of weeks' time. But none of the patient had a strict criteria of screening tools and admission and all those things. So we have a very, 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 very presentation. But in the hospital, yes, we have made a protocol in case if we have a positive patient, what all do and what to go for. So clinically, I'll say that lymphopenia, thrombocytopenia, and biological markers like ferritin assay, LDH may not be appropriate, and we need to have a wholesome clinical picture.
Dr. Vani, yep, you can actually share your thoughts.
Yes. So with due respect to when we talk about low resource settings, if you're talking about getting a serum ferritin level or even a leukocyte count stat is extremely difficult. We are actually a tertiary referral center in the suburbs of Mumbai. My numbers are very high because we are dealing with women who come from containment areas or clusters or hotspots. We use a very simple screening, and we are not, and the screening is done free of cost for our patients, thanks to being a government institution. Hence, the cost factor does not come into the picture. We categorized our patients into symptomatic and asymptomatic. So in 2 months, when I analyzed the data, we had 25 women who had come with fever and cough. So our triage included just asking a simple questions to the patient, and we got the infrared thermometers, the screening to see whether they were febrile or not. So if they fell into that category, they were classified as possible COVID and were delivered in a separate area. Again, you had that lovely video which was shown by Jeannie. We really have a constraint of where we can deliver. So it is, we do not have any negative pressure rooms. We cannot get a serum ferritin level done, nor can we get a D-dimer or a fibrinogen. So when we talk about low resource, even in a big hospital, in a big city with a big hospital, these are not available on the spot. So what do? Have a questionnaire, have a thermometer, and then if you feel the patient could be possibly COVID, deliver her in a separate area. And then after delivery, put her in a holding area. Having said that, let me just tell you, in the 25 symptomatic women, 54% were positive. But out of 800 asymptomatic women, we had a 10% positivity. And we have actually sent this for publication right now. And we feel that it will impact the screening guidelines for pregnant women in our country because it is a very large number. Because we were also surprised, and which is why our administration has supported us and continued to allow screening of each and every pregnant woman who comes inside. So hence, I think we need to be particular, and a 3-ply mask with a cotton mask is something which we are giving. And in fact, one of the lecturers had also pointed out that also give to the patient. Most of our patients come from an indigenous population. We are actually supplying the 3-ply surgical mask for the patient and the relative who is accompanying. Another beautiful point which was brought out, the visitors who come with a sick patient and those who come for a labor patient are different. In fact, we had to deal with the psychological agitation of some of the relatives who had come along, and then they said, oh, the patient next to me was later on found to be positive. And there were 2 or 3 relatives. So, there are a lot of these layers which you have to deal with. And hence we have insisted, and while taking rounds, we keep talking to the relatives and motivate them that please keep social distancing. Do not sit close to each other. Do not keep coming into the area post-delivery. You want to see the baby and other things, but stay away because you don't know which patient is going to turn out to be positive later. So
great. Okay, thanks, Dr. Wani. I think that was very helpful.
Dr. Arvind,
so,
I just
yep.
wanted to add one point.
Yep.
That in addition to the fever, I think we should also add lack of smell, because
yes.
fever and lack of smell probably will have a better,
Dr. Bhavani, we have a questionnaire with which has 7 or 8 points. One is also breathlessness, a change in taste or smell, and we ask that in the local language. So we have actually what we have done again to rationalize the use of PPE. One junior resident with one runner who will do the writing is sitting in the OG casualty area, which is separate from the emergency room of the hospital. And that person sits and does all this, takes the swab and sits for 6 to 8 hours, as long as they can bear to be in that PPE and not eat, drink, go to the loo or whatever. And they do the swab testing. Hence, then we don't have the wastage of PPE. So that person is looking after. And what you beautifully pointed out, there are many other questions. So we have that questionnaire, which is administered at the point of entry. Unless, of course, patient has come, sometimes patients come nearly fully dilated and you have nothing you can do. And in that case, we swab after the delivery.
Great. Okay. Thank you. So the third question is also very interesting. It relates to post-exposure prophylaxis. So this is a healthcare provider getting exposed to who was asymptomatic at the time. And then you realize a day later that that patient turned out to be COVID positive. And a specific question is, are there any drugs, or any evidence to suggest that one of the agents might be better than the other for post-exposure prophylaxis? I think this is a great question, and I think it's highly relevant to all of our practice settings. So I'm going to open this up to the panelists, and maybe if you can raise your hands, then I can call out your name. I see a few, I think it's the same names, same hands rather. Looks like Dr. Lisa Leffert wants to take a shot at that first.
So I will probably talk about something different from other folks. I think that is something that, in addition to a vaccine, people would be extremely excited to be able to find for obvious reasons. There is a lot of creativity in terms of what is being investigated. And I will tell you that nitric oxide, as an example, is being investigated in our institution, both because it is virucidal and also decreases the inflammation. So it's not only being investigated as a medication for folks who already are sick with COVID infection, but also as something potentially prophylactic. Now, that's not something that's available even in the United States to most people. It's purely experimental, but people are trying all kinds of different things.
Okay, thanks, Lisa. Dr. Wani?
Well, I didn't have slides, but we developed a flow chart of how to manage, because in the initial part of our screening activity, there was a lot of anxiety and a lot of quarantining of our healthcare providers because they had not been sensitized as to how they should manage. And all our swab reports were coming after the event. So we had that flow chart, but there is an ICMR FOGSI study going on in which we have been giving hydroxychloroquine to all our healthcare providers. All in my hospital, in also Nair Hospital, which is another municipal corporation aided hospital, which is designated COVID specialty hospital, which has 1,100 beds, which are now dedicated to COVID. All the healthcare providers, the residents, have been given packets of hydroxychloroquine for prophylaxis weekly. So that is being given regardless of whether they had direct exposure or not. Another thing which has been suggested, which I have implemented in my department as of last week, it was suggested that vitamin D also acts as a protective thing. So mega dose of vitamin D, in fact, I have actually acquired it from some sources and distributed it to all the healthcare workers working in the OBGY department. And of course, it's optional. Now, hydroxychloroquine, there was a lot of controversy on this. But we have found we have not had a single adverse event reported in our large pool of healthcare workers. And it's not by force, it's by choice. So 1 or 2 people who had some cardiac history or were hypertensive chose to not take it or do an ECG. and then decided to go ahead with it. But 99% of all our team is taking hydroxychloroquine, multivitamins, vitamin C, vitamin D. This is just common sense stuff. And we've told them, we've also got nutrition packets to be given to them, especially when they're going to be working long hours in the PPE and only hot liquids. So these are certain practical points which we advise our healthcare workers.
Great. Thanks, Dr. Wani. And I think, I have at least one answer to that question about post-exposure prophylaxis. So I was kind of looking up the literature. And what I found was that there was a group in South Korea, that's actually used a combination of ribavirin along with 2 antiretrovirals. It's ritonavir and lopinavir, which goes under the brand name Kaletra. And this was during the current COVID-19 pandemic. And they used it in about 200 healthcare providers who were exposed unintentionally to a symptomatic COVID patient. And it turns out, they did a kind of a randomized, kind of a pragmatic trial. Obviously, they would have liked to give it to everyone, but what they found was that, the incidence of the attack rate, rather, which is the proportion of patients exposed to the virus and getting converted to a positive COVID status, was much lower in this group that received the antiretrovirals compared to the group that did not receive any. So there are also multiple trials on clinicaltrials.gov. There are a lot of randomized controlled trials happening. One of that is called COVID-19 PEP for post-exposure prophylaxis with hydroxychloroquine. I know that for treatment, it may not work well and may have side effects, but we do not know for sure whether it's a good agent for prophylaxis. And I think we need to clearly have the distinction that treatment and prophylaxis are different, and maybe it might have some utility. So I'm going to stop here with this question and move on to a very practical question that was asked, and this was a recurring theme over the past 5 days of questioning. And what I found was one of the important themes is, how do you convert a laminar flow operating room to a negative pressure room? What are the practical tips? Obviously, negative pressure rooms are in scarcity, even, in high resource countries, and I know that it's extremely difficult to create that environment for delivering these patients. So I'm going to stop here, and I see Dr. Pandya raising his hands, so I'm going to have him take that question. And then I'm going to ask Dr. Shunchuke Hyuga how they do this in Japan, followed by Dr. Tangwi Wat on how they do this in Thailand.
So in fact, there are not many pregnant patients with COVID-19 in Japan. So only a small number of pregnant women have contracted COVID-19. So I have not enough the clinical experience of COVID-19 pregnant, but we make the rules to transfer the COVID-19 positive women to the negative pressure room, to the so dedicated to the elevators and to the negative operation room.
Great, thank you. Dr. Tangwiwat, how do you, do you have any plan in place to convert your regular positive pressure rooms to negative or neutral pressure?
Thank you. And we have a limit numbers of COVID-19 positive too in my hospital, but actually we prepare for the negative pressure room. And then while we're waiting during the setup, the negative pressure room, and so we use a HEPA filter in normal operating room. And that's it. Thank you.
Perfect. Yeah, Dr. Pandya.
Yeah, so creating negative pressure room from a regular positive pressure room, basically you need to have a good HVAC engineer in your hospital. And 4 of the theaters where we could do, and 2 theaters we couldn't. I mean, we are at 10 hospitals, but 2 hospitals we could successfully manage. And at Fernandez Hospital, we couldn't get negative pressure, where the policy is, when at the time of aerosol genetic procedure, we just switch off the AC and make it neutral. But in the theaters, other hospitals where we could create, basically the HEPA filter gives a fresh gas flow of almost about 65 to 70% flow is there over the table. And the return air flow at a given percentage about 45 to 55%. So 65 to 75 of fresh gas flow and return air flow from the theater is around 45 to 55. So there is a positive pressure of almost 15 pascals in most of the theaters. So what we have done is we have discussed with the HVAC engineer, and we have increased the return airflow to almost 100% in the theater, and the HEPA filter flow is reduced to about 35 to 40%. Yes, the cooling may temporarily be affected, but negative pressure is thus created. And generally, at the time of intubation and post-intubation, up to about 20 minutes, we maintain the negative pressure. And once the surgery timeout happens and the surgery starts, we get back to the regular positive pressure. And again, go back to negative pressure at the time of extubation till the patient is transferred out and doffing happens. So it's basically a mechanism which can be done if you have a close liaison with your HVAC engineer or the AC engineer in the maintenance department. And I'm sure they will be able to do that if you have a separate EHU for every OT.
Great. Thanks, Dr. Pandya. Dr. Balavenkat, do you have any thoughts on how to convert rooms to negative pressure or even neutral pressure?
I think globally it's a challenge, and especially in low resource areas, you can never have a positive pressure getting converted to negative pressure, both because of availability of the money as well as the technical person. So the ICMR guidelines also states that if you have the air exchanges increased, normally several of the air conditioning units have 6 to 8 exchanges per hour when it's a positive pressure. And they say that if you go more than 20 air exchanges per hour, the amount of the viral load becomes extremely less. So this could be much easier to do than do a positive to a negative pressure.
Great. Thank you so much. So moving on to the next question, and I think Dr. Vani might be able to help me with this one, because it relates to transfer of the virus to breast milk and the safety of breastfeeding in COVID-positive patients.
This is a very important point. And honestly, in most countries, the guidelines have mentioned there is minimal transmission through breast milk and meticulous hand hygiene, ensuring that the mother is wearing a mask. We can allow the mother to breastfeed, and that is the policy we have been following. We have had more than 102 mothers already discharged uneventfully. And in this entire series of patients, we have done COVID swab of the babies. All the mothers were breastfeeding despite being detected COVID positive, and only 3 babies were COVID positive. Of this, 1 was a preterm neonate who was anyway not being breastfed. The other 2 were detected later. So we are still following the policy of breastfeeding, and there is not enough data to show that there are any particles detected in breast milk. So it's just the mask and meticulous hand hygiene which has to be followed.
Arvind, can I just ask a question? When a COVID-19 pregnant patient comes, delivers, and goes home, discharges, I think she's going to go to the same environment which gave the disease. So what are the chances of the newborn acquiring the disease from the community?
So, Dr. Balavenkat, you know, this has also led to evolution of how we discharge the patients. What was initially the policy was asymptomatic positives. Even the municipal corporation had given guidelines. Asymptomatic positive women can be sent home and told to self-isolate in their houses and maintain distance from the household members. And whoever is the maybe one person who is helping her with the baby should also be wearing a mask and have proper hand hygiene. But having said that, now the policy recently last week has changed, and we have been asked to hold even the asymptomatic positive women detected by us in the hospital environment, because most of them are not able to follow this proper social distancing. And this, of course, logistic issues. Most of our women come from a place where they do not have a separate bedroom and toilet facilities. So that interaction is there. So they are supposed to be kept. And if by the 7th, 8th, or 9th day, they have no fever, no symptoms, they do not require to be swabbed again. They can be discharged and considered to be negative. However, if they do develop, and that incubation period, even an asymptomatic positive, is considered 5th to 9th day. So if any of them develop symptoms by the 9th day, we do a repeat swab, we swab the baby, and we hold them in the hospital until the next swab results come or until they become asymptomatic. So yes, we have to look at the social issue of sending them home and having them spread in the community, which is why we have also developed a second level of COVID care centers, because we are finding our hospital ward will then overflow. We don't have facility to keep them. So the government is developing these other intermediate kind of facilities where the patient who is asymptomatic can be sent to stay until she can go back to her house, where she cannot have enough place for self-isolation.
Great. Thanks, Dr. Vani. Jeannie, do you have any insights into the breast milk transfer and the safety of breastfeeding, and also homing of the mother-infant dyad? I think which will also be an issue in all labor and delivery centers.
Sure. So as I alluded to in the beginning, we actually separated babies from moms who were known to be positive or were persons under investigation by our CDC guidelines. This is a very traumatizing event for many of our patients who came in to not even be able to hold or touch their baby that they just gave birth to. And it felt, frankly, wrong to send a first-time mother home with a newborn. Part of our job as the maternity ward is to teach a new mother how to take care of her infant, and teach her how to breastfeed and teach her how to do those things. And it frankly seemed wrong to essentially hand a baby to a mom who had not even touched that baby since delivery on discharge and say, good luck. You have to now learn how to take care of this baby. And by the way, you're supposed to use all this protective equipment when handling the baby that we haven't taught you how to use. And so we radically changed the way that we were treating our positive moms and moms who were under investigation by allowing them the option, much like we treat our moms in the past who are positive with the flu, kind of a shared decision that we make with the patient and their family, whether they want to room in with their infant. We allow breastfeeding, including breastfeeding, we provide them with a pump, but also allow breastfeeding at the breast, teaching moms how to perform adequate hand and breast hygiene, teaching mom how to mask when handling the baby, teaching their support person who we allow for our COVID positive moms to strictly shelter in place and room in with mom with a mask as long as they're asymptomatic, because we felt like it was important that when we discharged them, they had experience and know the tenets of what a safe social distancing, social isolation, and breast and hand hygiene on how to handle the baby, the mother, and to cut down on that transmission as much as possible. In the hospital, we have a special fridge specifically for moms who choose to pump and or are separated from their infants because the mother is sick. We have a special fridge. Sorry, I have little visitors today, but specifically to store breast milk for COVID positive mothers, even though there has been no evidence so far to suggest the possibility of transfer from breast milk.
Great. Thanks, Jeannie. And I think, I'll move on to the next question. It's a hardcore anesthesia question. So I'm going to pose this question to Dr. Kodali and Dr. Podaway and Dr. Leffert. One of the most common questions that I see here is how do you decide between the use of regional anesthesia and a general anesthesia for a COVID positive patient? I know that you've addressed most of these questions in your slides, but I think this is something that people are really anxious to know. Maybe if you can come up with a mini flow chart, so that people can make quick decisions based on what's available to them, that'll be great. Bhavani, off to you.
Yeah, so I think the regional is the way to go. And I think my understanding is that the majority of the centers do regional anesthesia anyway in many parts of the world. So doing regional anesthesia for these COVID patients should not be an issue. And the only thing is, if the patient is asymptomatic and is coming and is COVID positive, it's very unlikely that the patient is going to have a coagulation defect. However, there is only one, if the patient is symptomatic, and that is a little bit of a tricky situation, you don't want to do an emergency intubation after giving regional and convert to GA. So that is a little bit of a judgment call. If the patient is already borderline desaturating and requires a lot of oxygen, her respiratory rate is already compromised, is tachypneic, those cases probably is well off with a general anesthesia, then starting regional and then converting to general. So that is why I said the first part is very clean, giving regional. Third part, where the patients needs general anesthesia because they're already completely respiratory compromised, is easy. It is in between that needs a judgment call. And if the patient has got respiratory compromise, then of course you may have to check on the coags, at least one set of coags of platelet number. As Dr. Lisa Lefort pointed out, you don't want to surprise yourself. There is only one report which I read where there was an encephalitis in a COVID-19 patient, but the patient has a frank weakness. That is why in my slide I said, do a good neurological examination before you give regional. And regional is probably the way to go. I think it avoids so much of aerosolization. And,
Thanks, Bhavani. Miha and Lisa, maybe in that order, if you want to take that question, if you have any valuable insights.
I think the decision to use regional or general depends on the patient status, probably independent of the COVID status, right? We always try to prioritize regional. We always try to have epidurals and go to the OR with good working epidurals if we have to. And the only thing I would say for COVID patients, that if you have a PPE shortage, if you don't have a lot of N95 or PAPRs, and you want to minimize the risk of exposure, you want to minimize the risk of aerosolizing the virus into the air, then really push neuraxial. So do that epidural a little earlier. If the tracing doesn't look great, move towards delivery earlier. But we highly favor neuraxial if no contraindications to neuraxial, if the patient is not anticoagulated.
Thanks, Miha. Lisa, do you have any input?
Yes, I agree with what both of my colleagues said, and I'll add two other brief thoughts. One is, if you have to intubate or extubate the patient with the criteria that my colleague said, think about putting a large clear plastic bag over the head of the patient. Since extubation is probably more aerosolizing than intubation, you can literally extubate under a plastic bag, and that can spread some of the air, stop the spread of some of the aerosolization. So that's one practical tip. The second is some of the issues that people worry about for neuraxial separate from coagulopathy is the concept of, am I going to spread the disease into the neuraxis? And I would say, whereas we don't know for sure, there isn't data to make us concerned that we are more than any other virus in terms of the level of viremia in the blood. Certainly if the patient has encephalitis already, then that means that there is already neuraxial spread. So there may be other reasons why you would consider to do or not do a neuraxial, but not that you are going to introduce virus into the neuraxis.
So it looks like Dr. Balavenkat has some input.
I just want to ask, just an addition to this, instead of when you think of neuraxial, is it a good idea to go for a combined spinal epidural in these patients so that you can limit the intrathecal volume and decrease the hemodynamic disturbances, and epidural for postoperative pain relief, because you can't use multimodal analgesia, especially the opioids, because you may lose the airway, or you may have airway manipulations to be done. Is there a role for that? And I don't do these cases, but just wanted to know whether that would help in good analgesia without people going into giving frequent injections for these patients.
Actually, I completely agree with you, Dr. Balavenkat. Actually, when we are going to do CSA has got an option that you can limit the amount of the spinal dose, because you don't want any hypotension in a borderline respiratory compromised patient. But the only thing is, as I think Dr. Podovi pointed out, that these cases are a bit of experienced persons. You don't want to have a wet tap in a COVID patient, when you're attempting a CSA. So I think CSA is fine. Initially, when I started doing regional, I was skeptical about spinal part, because I was trying to think, well, Jura is a good defense, against our spread of infection into the CSF. But subsequently, it got a little more comfortable when we were doing labor epidurals and things. So I think your point is very valid. You can give less dose of spinal and then top it up with thing, and that will also avoid the respiratory. So the patient doesn't feel immediately that she is unable to breathe.
So, Dr. Wani, I'll have to interrupt you for 1 second because there's one really important question which I really want to pose now before we conclude the Q&A session. And that is actually for procedures in labor and delivery that require sedation. Do you do oxygen administration? Are you aerosolizing by doing this? I think this is a very practically important question. And maybe, Sunil Pandya, if you are still there, you can probably... Yeah. So, I have the same concern to the extent that I've changed my practice, especially for DNEs, where we typically do TIVAs or sedation. We switched over to spinals so that we can avoid, putting a nasal cannula on, because we were not universally testing patients at the time. If you put a nasal cannula and running 3 to 4 liters of oxygen, you're obviously, aerosolizing something, right? And so I think it's an important question, and it's very practically useful. So if you can weigh in on that, that'll be great.
Yeah. So for the short procedures like DNC or ERPCs and manual removal of placenta, we give a single shot sitting spinal, which is good enough, because by giving TIVA, what we have realized in few cases is with fentanyl and propofol, they go into deep state, and then they take deep breaths, and that's what generates more aerosol. So I think regional is still, even though it's a short duration procedure, even like give an encirclage stitch, it is better to give a sitting spinal so that you can minimize the spread, and the requirement of vasopressors are almost negligible, unheard.
I completely agree with you, and I changed my practice. I'm a big fan of sedation and monitored anesthesia care, but I've completely changed my practice. I do mostly spinals for all of these procedures, exactly doing what you mentioned by, having them sit up for a little longer than they would, and creating a less, hemodynamically insulting spinal block. Dr. Balavenkat, do you think we should wind down because we are close to, yeah.
Yeah, I think before we wind up, I think it'll be interesting to note the perspective of every panelist and the speaker. According to their judgment, how long do you think that this new normal will exist? I think we'll start with Dr. Meeta.
I don't know. I think it's hard to say. I think this is going to circle the globe and then go back to us, right? Like we had a wave and then it's down, but I don't see a reason.
Can you put a number for that?
How many months into this?
Yeah.
I don't know. I think this is here to stay. I don't think we can hope that by the summer or by the fall, this is going to all go away. I think the good news is that we found ways to safely work. Like my institution, my healthcare system has 75,000 employees, 50,000 come to work every single day, and we don't have major issues, despite the fact that we were one of the hot centers of in the US. So I think basic stuff like barriers and masks and, distancing and cleaning, like we passed the wave and we're doing better, and we didn't really compromise our safety. So I think we just have to learn to live with this for the next, who knows how, but at least months.
Any other difference of opinion for this?
No, I think, there are 3 possible, outcomes. So one is very unlikely. Initially I thought it would be a scorched earth, policy where it'll come in, completely, disrupt, cause chaos, and then completely disappear, like what SARS did and what MERS did. But this is a much more perfectly designed virus. It's much more sneakier than the other two. So I think it's going to persist for a really long time. And I'm also following the vaccine science quite intently. And the more I read about it, the more pessimistic I am. I know that people have been describing a timeline of 12 to 18 months, but I'm extremely skeptical whether we would have a vaccine that's going to be effective and safe. And, being a healthcare provider and a risk taker myself, I would be very hesitant to get a vaccine that's been pushed through the pipeline with minimal safety data. So that's the other problem. And I think what's going to happen, whether we wish it or not, is going to be herd immunity. And I think that is the reality that's staring right in front of us. And I think the goal would be to keep the people who are, at high risk for developing the severe disease safe, and try to work around it and try to keep everything going. I don't think we should allow this to disrupt our practice. I strongly suspect that it's going to go on for a really long time and smolder in the background.
So I think the message, yes, Dr. Lisa?
I'm not sure this speaks for herd immunity, but two thoughts come to mind. One is we were the third hardest hit state in the United States and the hardest hit institution, and we're already expecting another surge in the fall. So to the point of this is certainly not done. In terms of protection of healthcare workers, and we have been pretty successful of that, it has not actually been a lot of fancy PPE use. It's some of the things that some of your colleagues have mentioned. It's patients wearing simple barrier masks and a lot of hand washing. And those have been two of the most important aspects of safety for everyone involved. So I just wanted to put that out there. Thank you.
And actually, one point I would like to add from what you said, I think our lifestyle will change forever after this. We wash our hands so many times that I lost my fingerprintings all on my hands now. I don't think I can be fingerprinted anymore.
So you cannot operate your 73 devices connected to your internet, Bhavani? Dr. Wani.
Dr. Balavenkat, to answer your question, I would say a timeline of minimum 6 months. And I feel, as Lord Tennyson had said, that the old order changes, yielding place to new. And God fulfills himself in many ways, lest one good custom should corrupt the world. We need to move with the times. And I have instructed my entire team that you have to change the way you think. What you spoke about, that pure anesthesia question, we are only doing saddle block and spinals for all. We have done more than 30 DNEs in COVID positive patients. We have done almost 40 cesareans, only 4 required GA. And that was because it was severe preeclampsia, or somebody would come with a convulsion or breathlessness. Everything was done in spinal. There is no epidural being given for labor anesthesia because we don't have that facility. But we have changed, and even in the low resource settings, we are able to do it, and we have to change the way we practice. And I think it's going to stay, but we have to be positive, not in the test sense, but be positive in our outlook and move with the times. And that's the way forward. So I think that's what I need to say.
So I think Jeannie has an opinion, followed by Dr. Sunil Pandya.
This is actually just an important point that I wanted to make, hearing Dr. Leffer talk about masking patients. We thankfully have not had a huge unit outbreak due to patient to provider transmission yet here. However, we have had unit outbreaks from provider to provider transmission. And I think that is a route of transmission that we have to remember and have to keep in mind, especially in the practice of obstetrics and maternity care, where it's not these small nursing units that we see on other units, but a large nursing unit where anesthesia, obstetrics, pediatrics, neonatology, all of these groups conglomerate onto this one large room. And we really have to be mindful of provider to provider transmission, which actually has taken down some of our units here in Missouri.
Yeah, absolutely. I think that's a great point, Jeannie. I think it's really important that providers don't accumulate in the break room all at the same time, chit-chatting, which is what typically happens. I think we should be very mindful of that, because we recently had an outbreak where 11 out of 16 healthcare providers from one unit tested positive all at the same time. So just keep that in mind. And Dr. Pandya, sorry to kind of interrupt because I just chimed in.
Two things, one comment and one question. See, one other thing that we have seen, and several papers have come out of it, even in NEGM, that a patient, asymptomatic COVID carrier, when they undergo surgery, they present differently. The incidence of cytokine storm is almost increased to the tune of 27 to 32%. Patients who are undergoing cesarean sections, probably we need to watch them for the cytokine storm in the post-operative period, which generally occurs 5 to 7 days later. And many a times, our discharge policy of our patients following C-section, third day or fourth day, we don't keep them for a week. But these patients, probably they may have to be observed for a little longer time, observed for cytokine storm, and if necessary, we may have to escalate the therapy. Dr. Arvindra Bhavani or Lisa, anybody, is what is the role of Entonox in hospital?
I know that Lisa cannot take that question, so I will. there's a little bit of history behind that, but I personally feel that one, the quality of analgesia is in general poor, and there are other concerns with Entonox use, and especially in this setting. In the middle of a pandemic, I don't think we should be entertaining Entonox use. It's one thing if your institution has a universal testing policy and you have someone who's completely asymptomatic and requesting Entonox, but it's one thing if you don't have the testing policy and you really don't know who is positive. Giving them Entonox is definitely going to end up aerosolizing. And these are patients who you could have actually prevented labor pain with a good working epidural and preventing them from hyperventilation and aerosolization. So I think, I usually don't take really strong opinions, but I do have a strong opinion against Entonox use.
I hope my colleagues are listening. I hope my colleagues are listening. Good.
No, I completely agree with Dr. What Arvind has said. And I think it is probably better to place epidurals early and avoid subsequent GA and the aerosolize. Yeah, absolutely.
Concur with that, yes.
I think we had excellent discussion. Arvind, do you think I think we should wind up?
I think we should wind down this.
One of the most positive things that COVID has done is to make the whole world a global village in terms of communication. I think all of us are here together with nearly 5,000 registrants from 63 countries wouldn't have been possible. So there are some positivities. And may I request our Secretary of Aosra-Pm, Dr. Suvimon, to propose the note of thanks to all the faculty and to the participants.
Thank you, Dr. Bala. On behalf of Aosra-Pm, I would like to thank the 5 speakers from USA and 3 panelists and all delegates, and Summit Medical for supporting us. And this is the second webinar conference under Dr. Bala Venkat, the president. And we hope to continue the activity like this again. Thank you.
So thank you so much. And we look forward for the next webinar, which is on the 27th of June. This is on COVID and patients with malignancy and who are getting treated for malignancy. And thank you so much for each one of you for contributing on time and exchanging your thoughts and expertise. We look forward to meeting you again, and have a lovely weekend. Thank you so much.
Thank you, Dr. Bala.
Thank you.
Thank you.
Thank you. Bye-bye.